Now, good. Now, let us look to another class of antidiabetic drugs which works at the renal tuberous to prevent the absorption of glucose. It's a very important drug which has what we call the triple advantages. It is good for kidney disease, it is good for diabetes, and also it has cardiac benefits. So it's a very important drug, and let's see this type of class of drugs. So in this type of class of drugs, we call them sodium cotransporter inhibitors. An example is dapagliflozin, which is combined with metformin. We have dapagliflozin, which is combined with azathioprine, and also canagliflozin. We have canagliflozin combined with metformin. We have empagliflozin. Empagliflozin is marketed in Kenya by various companies. So we have empagliflozin plus metformin. You have empagliflozin plus linagliptin and empagliflozin. So you can see that it appears as a specific drug, and also it appears with other drugs. And there is so many reasons depending on the therapeutic interest of each prescribed drugs. So let us first of all look at how our normal body handles glucose. So in a normal person, glucose filtration enters the glomerular. Then at the proximal tuberous, the first part of the glomerular tuberous, 90% of the glucose is reabsorbed, whereas at the second part of the proximal tuberous, 10% of the glucose is reabsorbed. Then on the loop of Henle, there is water reabsorption, distal, some minerals, and then correcting that minimal excretion of glucose, because amount of it is reabsorbed in the body. That is in a normal person who is physiologically functioning well. Now, there are some basic things we have to understand as we proceed with this lecture. Now, and one of the basics is that we have to understand that what is the plasma glucose concentration? The plasma glucose concentration is 5 to 5.5 millimoles per liter, whereas the plasma filtered in the glomerular is 180 liters per day. Whereas glucose filtered is 160 to 180 grams a day, and then the glucose excreted is expected to be minimal because of reabsorption. Remember, we are talking on somebody who is physiologically sound, not a patient. Now, let us see what happens in somebody who has type 2 diabetes. What is going to happen? In this type of patient, what happens is that there is glucose filtrations at the glomerular. Then at the proximal tuberous, there is, when you give sodium glucose cotransporter, they stop the first part of the proximal to reabsorb the 90% of the glucose. So what is reabsorbed is the second part of the proximal tuberous, which reabsorbs 10% of the glucose into the blood. So that means 90% is not reabsorbed. So this means that the glucose in the blood, the glucose in the blood is reduced. So that means in this case now, there is marked increase in excretory of the glucose in the urine. This means that this patient will have glucose in the urine, because a part of 90% is not reabsorbed in the past part of the proximal tuberous. Now, in this case, what are some of the basic things we should understand is that the plasma glucose concentration in this case is 10 millimoles per liter in this now type 2 patient. In plasma filtered is 180 liters, This is one again in a type 2 diabetic patient, and the glucose filtered is 350 grams per liter, and the glucose excreted is 70 to 119 grams daily, which is equivalent to 80 to 476 kilocalories per day. That is now in a diabetic type 2 patient. So this one you can compare, remember, with the whatever you have discussed up there in a patient who is normal. You can compare in this type of patient who is normal and this one who is diabetic type 2. Now, let us see what is hypoglycemia and the cardiovascular risk, the possible links in this type of type 2 diabetes patient. Now, the hypoglycemia and the cardiovascular risk in type 2 diabetes is linked to number one, to hemodynamic changes, ECG changes, and immunological changes. Like in hemodynamic changes, there's activation of autonomous nervous systems with the 10 to 15 fold increase in secretion of adrenaline. And you remember that the adrenaline, these are the ones which act against insulin. They act against insulin. Their antagonist is a part of the hormones which antagonizes insulin in our body. So there is ECG changes, there is a long QT interval, and there is hypokalemia. This one results to arrhythmias, and that means the heart is not pumping well. There is no coordination of the impulses between the atrium and the ventricular, and this most likely the heart can draw an emboli, which can rest to any part of the body, and it can block and cause a sudden death. So again, there is immunological changes like the protect activation by the protect activation factor, resulting to coagulation, intravascular coagulation, and also increasing viscosity of the blood because of the increased protect activations in blood vessels. Now, those are the the cardiovascular risk in terms of hypoglycemia. So now let us see now type 2 diabetes leading to dual inhibition. How does this sodium glucose cotransporter inhibitors lead to dual inhibition? So there is the glomeruli. You can see the glomeruli is having a lot of blood from the efferent. The efferent has filtrations. There is sodium in the proximal tuberous. There is glucose. There is now the sodium glucose cotransporter. Then there is in this case now, if there is this sodium glucose cotransporter, it inhibits the absorption of the 90% of the glucose back to the blood system, meaning that the sodium and the glucose will be excreted, resulting this patient will have to pass a lot of urine with a lot of sugars and a lot of salt. So that is what this one works. It works at the proximal, the first portion of the proximal tuberous. Now, what is how does the gracilia lowers HbA1c and reduces glucose toxicity? The glucose is reduced, resulting to reduced glucose toxicity and insulin resistance, which results to reduced tissue inflammation and oxidative stress. Oxidative stress, that is oxidative metabolism in the smooth reticular endothelium in the mitochondrium. So in this case, there is potential increase in endothelial functioning. You remember that the endothelium is the key stabilizer in the blood, in the circulation system. The arterial walls structures are maintained and the cardiac functions is maintained. So that is how these lowers HbA1c and reduces glucose toxicity. Now, glucose is increase in glucose excretion causes loss of total body fat mass. So reduced glucose results to reduced calories and fuel and circulating insulin. It increases rate of lipolysis, and this one results to lipolysis leading to weight reduction and potentially improves cardiometabolic risk because there is breakdown of fats. So multiple mechanisms may contribute to cardiovascular benefit by use of this sodium glucose cotransporter inhibitors drugs by reducing reducing HB12, which HB12 reduces glucose toxicity and inflammation. So that one is the inhibiting glycosuria, resulting to reduced HB12, resulting to reduced glucose toxicity and inflammation. On the other side, now on the electrolytes, the sodium, that is, there is excretion of sodium, that is natriuresis, resulting to reduced plasma volume. And the reduced plasma volume causes increased hematocrits, and this hematocrit means that there is a lot of hemoglobin, meaning that the blood can carry enough, a little amount of blood can carry enough oxygen and to various parts of the body. And also reduced plasma volume causes reduced preload, preload. So let us see how natriuresis reduces plasma volume and may enhance oxygen delivery to the organs. So increased urine volume and reduced plasma volume leads to increased hematocrit, resulting to increased oxygen supply to various organs in the body. We know the various organs of the body which requires oxygen is like the brain. So this one increases potential improving functioning of the cardiac, the heart functioning improves. So in this case, that there is increased urine volume, resulting to increased plasma volume, because you are passing a lot of urine, so the plasma volume is reduced, and this one results to reduce the venous return and reduced cardiac preload and a reduced arterial pressure. All these ones result to reduced myocardial stress, because the heart is not doing a lot of work. The work and the job the heart was doing of pumping a lot is reduced, and this one increases the potential cardiac functioning, resulting to reduced risk of arrhythmias. Now, so in this case, let us see how this one improves. Like the natriuresis reduces blood pressure, resulting to stiffness in this case. So now, you can see also the reduced plasma volume reduces hematocrit, resulting to increased oxygen delivery, and also reduced preload, reduced myocardial stress. This one results to cardiovascular benefits. So let us see, raw plasma volume is expected to reduce blood pressure and decreases afterload. So in reduced urine volume results to reduce plasma volume, resulting to reduced blood pressure, and this results to reduce arterial stress and endothelial injuries. This one potentially improves endothelial functioning, arterial wall structure and functioning, and cardiac functioning via increased afterload. So in this case now, you see that reduced plasma volume may result in neurohormonal activation and influence risk of arrhythmias and influence the risk of arrhythmias. So in increased urine volume, output result in reduced plasma in the body, resulting to neurohormonal activation, which activate the RAS pathways and SNS pathways. So the RAS moderate vasoconstriction and vasodilatation, whereas RAS and SNS may influence the risk of arrhythmias and cardiac and renal functioning, either erectile or via changes in blood flow. So in this case, now you see that the other one is there's reduced arterial stiffness, goes of reduced blood pressure, resulting to reduced atrial stiffness. That means there is reduced peripheral resistance, resulting to increased cardiovascular benefit. The other one now is the tubular macular feedback by macular denser cells, which causes reduced renal damage. And let us see what this one results about. So in this case now, the diabetes causes glomerular hypertension, that is called diabetic nephropathy, because of increased glucose and sodium transporter. So what happens is that the glucose in the glomerular afferents is increased, resulting to glucose increasing in the tuberous. Now, the macular denser now will sense this one and then send a feedback. So you can see on the proximal tuberous, there's sodium, there's glucose, and there is the level of sodium glucose transporter, which at that point now it is open. So that means there is a lot of reabsorption of sodium and glucose back to the circulations and then past part of the proximal tuberous, meaning that minimum glucose is excreted, minimum sodium is excreted in this patient, so this patient is having excess glucose in the circulation. Now, but this one, the system works, and now let us see what happens. In this case, now you can see now the sodium glucose transporter has blocked the entry point of the glucose from the tuberous, proximal tuberous to the brass, so meaning that there is no reabsorption of around 90% of the glucose, meaning that there is excessive glucose and sodium excretion in the proximal tuberous to the root of Henle, and then all the way the macular denser. So the macular denser is the one which senses the concentration of the fluid in the tuberous, and also the concentration of this sodium in the tuberous. Now, this one results to reduced glomerular filtration rate. Now, how does this one comes to do? So in this case now, there is increased in glucosuria, excessive glucose in the urine resulting to total body reduced in body total fatty, which results to ketones utilizations, On the other hand, the tubular macular feedback on natriuresis is the reduced renal damage, which is an additional advantage to cardiovascular benefit. So let us say free fatty acids plus low insulin and plus high in glucagon leads to increased ketogenesis, and lipolysis leads to increased free fatty acids. If low insulin and high glucose, then means that free fatty acids and the ketones means now the ketones can start circulating in the body. So in this case, let us see the ketones are more efficient cardiac fuel source than glucose. So you know very well that the cardiac, the cardiac cells get more energy from the ketones than from the glucose. So the mitochondrial energetic of oxidation is that oxygen uses B-hydroxybutyrate 101, and glucose produces one that 4 other purine 56. So the heart combination of calories minimum is 487 in beta and hydroxybutyrate, and 670 in glucose and 279 in purine. So oxygen cost of calories is 207 in beta and hydroxybutyrate, and glucose 200 in glucose, and 201 in purine. So you can see the ethyl combination of calories unit is that 244 in beta and hydroxybutyrate, and 244 in glucose, and purine in 186. So in terms of oxygen cost, the energy earned of beta and hydroxybutyrate oxidation is compared to those of glucose and purate. If the energy earned is calculated per carbon unit, beta hydroxybutyrate oxidation is superior to glucose and purate. As a consequence, in the isolated working heart, beta hydroxybutyrate increase external cardiac work at the same time as it increases oxygen consumption, thereby improving cardiac output efficiency by 24%. So you can see that basically the ketones provide more efficient calories to the heart muscles, to the heart cells than the glucose. So in this case now, you can see now there is ketones utilization resulting to cardiac benefit, and also on the other side there is sodium and hydrogen exchange resulting to increase mitochondrial calcium. Now, direct cardiac effect through impairment of myocardial NSA and flux independent of sodium glucose co-transport activity in animals studies shows that reduced intracellular sodium and the calcium in myocardium result to reduce sodium influx to mitochondria, resulting to increased calcium in myocardium mitochondria. And this one, calcium is needed for mitochondrial functioning and it may reduce reactive oxygen species and the production of increase in ATP production. Now, in this case, what does that mean? So, increased uricosurial result to reduced oxidative stress. And on the other side is that increase, you see that increased mitochondrial calcium result to reduced cardiac benefits. So, further hypothesis on the mechanism of cardiovascular protection in uric acid is that increased glucose excretion result to increased uric acid excretion and reduced plasma uric acid, resulting to reduced cellular oxidative stress. And this may lead to improvement in the atrial structure, stroke functioning of the atrial, reducing the peripheral resistance, and also increases the cardiac functioning. So in this case, what do we say? We say that in this case, we say that the sodium glucose cotransporter inhibitors act in two ways. In the glycosuria, that is excretion of the glucose in the urine, and also excretion of nucleases, that means of sodium in the urine. So in this case now, you see that in summary is that a reduced HB1 results to reduced glucose toxicity and inflammation, which is a cardiovascular benefit. Reduced total body fat due to glycosuria results to ketone utilization, which is an advanced cardiovascular benefit, and also reduced uricosurial, reduced oxidative stress, resulting into additional cardiovascular benefit. So, in the other side of the nucleases is that you can see that there is plasma reduced plasma volume, resulting to increased hematocrits, resulting to increased oxygen delivery, which is a benefit to the cardiovascular system. There is reduced plerone, resulting to reduced myocardial wall stress, which is a benefit again. And also there is reduced blood pressure, resulting to reduced atrial stiffness, which is an additional benefit to the cardiovascular system. So in the macular denser system, the tubular and glomerular feedback reduces renal damage, which is a cardiovascular benefit. And also sodium hydrogen exchange increases mitochondrial calcium, which is also an additional to cardiovascular benefit. So in a summary, that's known or unknown known about a possible mechanism of responsible for the benefit of sodium glucose cotransporter inhibitors is that on top of glycemia lowering with sodium glucose cotransporter inhibit demonstrate additional clinical benefit in one: blood pressure lowering, weight loss, reduction in major cardiovascular event in patients with established cardiovascular diseases. So the mechanism responsible for the cardiovascular effect are currently unknown, and it may be combination of nucleases, glycosuria, and or sodium hydrogen exchange. Ongoing mechanization studies may provide an answer to this. And thank you very much for listening to this one. So you can see that sodium glucose transporter is a very important drug with so many methods of doing cardiovascular protections in patients who have this disease. And at the end of this, we are ending this lecture until next time. Most